So if we use ultrasound, we can use it certainly on the shoulder. That was the first.
You want everybody close to the table, or we should keep sitting?
It's okay.
But it will be on the screen now. So.
They put it on the screen, yeah.
Yeah.
I think that here, so. So certainly, first slide was that was some effects of a rotator cuff. The rotator cuff is like a tire above the surface of humerus bone, and we can administer the STABHA directly to the lesion. So we can found the lesion and to put it directly there. If we have the bursitis, subacromial bursitis, we can use it in this hyperabduction. Then we can see fluid in the bursa, and then we put the STABHA directly into the fluid. So it's very precisely, and we cannot miss the place which is interesting for us. Certainly, when we have tendinitis of along the head biceps tendon, we can find the biceps groove. Just a moment. To visualize. Just a moment. Here we are. Can you visit? Yes. So in this moment we are direct on the biceps tendon. When there is an irritation, there is anechogenic rim. We can also visualize here the transversal ligament of humerus. So in this moment, again, we can administer the hyaluronic acid directly to the place of interest. When we use it to epicondyli, so we find the bony surface, that's it. Can we freeze it? So in this moment, again, here we can see the bony surface. In case of epicondylitis, there is an inflammation. It's again here hypoechogenic rim, and we put it directly into the position. Then very useful is you can to use we can use the STABHA by the jumper's knee. Sorry. Freeze, please. So in this moment, here we have the apex of patella. The inflammation is mostly here, so we put up the STABHA directly where the arrow is. If we have tendinitis, as we can see it on ultrasound, we put it directly to the deep layer of, that means dorsal layer of the patellar ligament. But it's not only patellar tendon, we can use it also by collateral ligamentars, which are very good visible on ultrasound. Here is the menisci, and here is the collateral ligament. Can we stop it? In case of irritation, it's not, sorry, it should be better to put it like here. So it's the layer is normally hyperechogenic, but in case of damage, we can see the hypoechogenic, more thickness or alteration of ecostructure of the collateral ligament, and again we can put STABHA directly to the lesion or to the injured collateral ligament. So the problem is very easy to solve by injection directly to the injured place. The last thing, can you take off your on your belly, on your belly. Now this posterior approach is very important, not only to visualize Achilles. In this moment, we can see here that is the calcaneus. Here is the prepatellar, bursae preachillei, and the Achilles. So if we have tendinitis of Achilles, we put STABHA in this region. If we have bursitis, preachilles bursitis, we put it in this region. And very important is that in this view we can visualize the dorsal rim of tibia, and from this view, only with another depth, we can find just a moment. We must change a so okay, we can freeze it. So in this moment we can see also the trochleatally, and when we measure in quiet position this distance, and then in forced position, if the distance is bigger, 3 millimeters, also in comparison with contralateral side, it means the ligamental lesion, and we know that it's distortion grade 3, and we have insufficient anterior fibulateral ligament. So with this cut, we can distinguish very easy, quickly the distortion grade 3 without any problems. What's only necessary when it's acute trauma, it's necessary to do this examination in local anesthesia because of pain. So then last view maybe, it's the origin of Achilles. Here we can see also the calcar. Here is small tractional exostosis, a small incipient calcar. Sometimes it's bigger. So it's only one possibility of what to use directly to Achilles, and that's STABHA, because we cannot use steroids. But certainly if the calcar is painful, we can use STABHA without any risk and side effects. Sorry. So it's only one possibility what is possible to be installed directly to the dorsal calcar. We can certainly use it also for plantar fasciitis. So in this moment we can see the origin of plantar aponeurosis. When we have plantar calcar, it's visible here in this position. This is certainly a very quiet region, but if we use STABHA, we put it, we infiltrate in the hypoechogenic inflammatory region with very good effect. So it's overview of possibilities very briefly, very quickly, but you can see that it's possible to focus our treatment on the right place immediately.
What about lateral ligaments?
Lateral ligament of the ankle? Yes, certainly we can visualize it. It was demonstrated very nice in a Canon presentation yesterday. Certainly we can visualize it directly. Can you freeze it, please? So this is the anterior fibulatellar ligament, but certainly we can inject directly to the ligament if there is a lesion. But on the quality of and stability, it's not directly given, but with the shape of the ligament, we can the stability and instability. That means differentiation between grade 2 and 3, what's very important, because they are, according to the international classification, two different diagnoses. It's S9-2 and 9-4, distortion and rupture of ligaments, and we need to do additionally to this view the stress position. And after that, we are sure that it's instability, acute instability. So we can distinguish in few minutes grade 3 and to have differential diagnosis between 2 or 3 degree of the ankle instability, ankle distortion.
Is it the same dose between acute and chronic?
The approach is the same, certainly. We can use two different approaches for forced position. This is the dorsal.
The dose. It's enough for chronic to give only one injection?
For chronic, it's difficult because chronic instability is elongation or absence of the ligament. So we can help from the problems, but we cannot recover the ligament by STABHA. It's only a helpful method, not causal treatment.
Are you recommend ice after this injection?
It's not necessary. The pain goes
For
away in
2-3 days?
No. The pain goes away in 2 or 3 minutes. I have also experience with my collateral knee ligaments. In 2 minutes, I have no pain.
Nice.
So it goes very quick away because it's the drug is compatible with the internal situation.
Thank you.